All right. Well, good afternoon, folks, at least folks on the East Coast. I'm actually in Chicago today. I was at Central Time Zone because I'm here with a bunch of events. There's the ASCO conference, there's Taylor Swift, there's a Liberty game and whatnot. And I'm glad that all that's happening. But so we're going to have a talk on lupus, a lupus chat today. And maybe we can get the lupus chat as big as this ASCO conference that we have here. And with that, I'm going to turn it over to Akeia Blue, who helps co-lead our communications at NMQF. She's gonna, being the communications guru that she is, she's gonna lead this conversation today. So turn it over to you.
Thank you so much, Brandon, and good afternoon, good morning to everyone. Happy Friday. We are so excited to have you join us today for this discussion about lupus. As Brandon mentioned, my name is Akeia Blue, and I'm the Health Communications Director here at the National Minority Quality Forum, and I'm just very excited to have you all here today. Before we get started, I have a few just very quick acknowledgements, some links and information to share with you all. So I want to first give a shout out today to our team, the Sustainable Healthcare Quality and Equity Team, also known as SHC, here at National Minority Quality Forum. They do awesome work bringing programming into the community. And so we're going to drop links into the chat in just a moment, but you can learn more about them. And as well, they have a wonderful resource that's full of information on a variety of health topics. And that's called the Health Champions Toolkit. And I recommend everyone sign up for the newsletter, check back into the website. We're constantly updating it with information, including we'll be updating it with lupus and clinical trial information. And additionally, for healthcare providers that are on the call, SHC does have their Demonstrating Real Improvement in Value and Equity, also known as their DRIVE program. They have toolkits that are available for healthcare professionals to help improve health outcomes for diverse and underserved populations. And the lupus and clinical trial modules are available on their website right now for you to review. Finally, we want to thank our partner Biogen, who is working with us to help us bring this important information to the community, particularly this lupus and clinical trials information, and reaching out to the Black and Brown community who is so deeply affected by lupus. They have a wonderful website with information about lupus and various clinical trials that you can check out. And so all of these links that I just discussed, I'm going to drop into the chat right now. And so feel free to check them out and get more information about these different entities. All right. So today we are here to talk about lupus and particularly the disparities in care for Black and Hispanic women. And this topic is deeply personal for all of us who are on the call today. I personally have a very dear aunt whose house I grew up in, who has lived with lupus for about 40 years. And so I've seen firsthand the challenges that she has dealt with and has had to overcome. I'm really happy that we are here to discuss how we can all help to improve health outcomes, particularly for Black and Brown women living with lupus. So our discussion today is with some amazing leaders in the community. I've had the chance to meet and discuss with them before and learned so much from them. We will have a brief presentation first, and it'll be followed by a panel discussion where we'll talk more about the personal aspects of lupus. And there will be time for questions at the end, but please feel free to drop your questions into the Q&A or the chat box as they come up. So as I mentioned, we have a wonderful host of speakers today. Our first speaker is Dr. Sarfraz Hasni, who is the Director of Lupus Clinical Research at the National Institute of Arthritis, Musculoskeletal, and Skin Diseases of the National Institutes of Health in Bethesda, Maryland. We are also joined today by Bishop J.L. Carter and First Lady Cora Carter, who lead Ark Church in Baltimore, Maryland. And I'm going to drop the link for their church in the chat as well. I highly recommend you check it out. I had the opportunity to visit them for service a couple of weeks ago. And when you talk about a welcoming church and a church that cares about not just the godly health, but the mental and physical health of their members, our church, and they didn't pay me to say this, I promise you, they are a great church. So at this time, I've done all my introductions, my acknowledgements, and it's really time to get into the discussion at hand. So I would love to turn it over to Dr. Hasni to give us a presentation of an overview of lupus and the challenges that we're going to be discussing today.
Thank you so much, Akeia, and thank you for this very kind introduction, and thank you for the invitation, and especially to your organization and Ark Church and Bishop Carter and First Lady Carter, for bringing lupus on the map and having this discussion here, especially in context of minority patients. It's something which is very near and dear to my heart. And as you have mentioned, that almost all of us can relate to that. And we had an in-person session, which I really enjoyed. And now we're doing this webinar, just kind of increasing the casting net. I have a brief presentation that I would like to share with you, and please feel free to interrupt or ask questions as you go, because we would like to have this more of a discussion than than just like a monologue. So let me see. Okay, so again, I have to probably swap the presentation. All righty.
Perfect.
So yeah, thank you. So I sort of label this as what can I do to help cure lupus? Because my understanding is most of you are either have lupus, or physicians or healthcare providers, or somewhat related to someone who has lupus, or trying to treat or help patients with lupus. So why is it important, and why is it important in the context of minority population? As you can see here, the data clearly shows that it's very common disease in African Americans. So African American patients, due to multiple reasons, are very disproportionately affected by lupus, to the point that 1 in every 250 young female in United States is considered to have lupus. And not only that, they are more commonly affected. It's a sort of a double whammy that they are affected by lupus at a much younger age, and their lupus is much more severe than the non-Black and non-Hispanic patients. So since lupus is considered to be the great masquerader, and a lot of things can look like lupus, and most importantly, most of the patients with lupus are young, female, and say so much resilience and body reserves that they don't look sick, but they feel sick. And I think when we hear from some of the panelists later on, they can share their personal stories that how it takes so long for getting a diagnosis of lupus. So on average, it can take 2 years or even more, sometimes 5, 6, 7 years, and it can take up to 2 or 3 healthcare providers going. So not only is that frustrating, but it has consequences. And the consequence is that this delay in diagnosis is devastating for a person with lupus, not only on a psychological or emotional basis, but also on a organ damage basis, because the longer the lupus goes on, where it keeps on affecting your body, keeps on damaging various body organs, it much more increase in the burden, and then causes much more severe complications. And again, you have to kind of think about that most of the people are in their 20s or 30s when they start having these symptoms. So they have rest of their life. So if they have this severe organ damage at such a young age, then they have to live with this disability for the rest of their life. So it's very important that we understand, and especially for the healthcare providers on the call right now, is that if somebody, especially a young Black female, come to you and have these non-specific complaints, so I don't feel well, I'm fatigued and tired, or my hair is falling off, or I go out in the sun and I'm having a rash, don't dismiss that, and make sure that you at least run the test and take it seriously, because again, that delay in making that diagnosis can mean life and death for a patient, especially the patient who are belonging from African American, Black communities, or Hispanic communities. So so as a Black female, if you have lupus, then statistics shows that, and things have changed, and we are trying to change them, make it better. But these maybe look very depressing to some of the patients, some of the people who are looking at this. They're 3 times more likely to develop lupus, and there is an increased risk of hospitalization. It's just this comparison among patients who have lupus. So just being Black, having lupus, there is an increased risk of hospitalization. They are much more likely to develop kidney disease, which is one of the most devastating involvement of lupus with the internal organs. They're 3 times more likely to die from lupus. And not only they are 3 times more likely to die, they die at a much younger age. So their life expectancy significantly reduces. And of course, these are averages. So for one patient, it may be different and from the other patient. But on average, patients who are African American descent, who are Black, their disease is much more severe and they have much more internal organ involvement. So what can we do to help this? So the problem is that not only that the disease is more severe, not only that they don't that they have much more hospitalization, the response to treatment is different. So patients who are African American ancestry, the genetic makeup is different, obviously, from patients who are white. And when we give them treatment, they don't respond the same way as patients who are white. But the problem is that their participation of Black patients in clinical research, especially clinical research in lupus, is much less as a proportion of their population. And over the last 30-40 years, there have been various attempts to increase their participation. But I was looking at the graph, and it's pretty much stays the flat. And in fact, if you look at more closely, the graph of participation of African American Black patients in clinical research as a whole, in proportion to their population in US, has actually went down. So we need to encourage patients with lupus to be involved in clinical research, because we need to get data which is generated by patients who have the same genetic makeup, so we can see which drugs can work for them better, and not use the data from another set of population and try to treat them with that. So that is very important. And then not only that, it will also help us understand that why is it that being a Black person, that the risk of lupus is so much high, and why is it that the disease is so much more severe. I mean, people have looked into it to some degree, but until and unless a large number of Black people participate in clinical research and then come to centers such as NIH, where we can learn about this, we would not have the answers for them, and we will not be improve the outcomes and make things better for them. So that's why I have this here saying that improving lupus outcomes through clinical research. And what it means is that the lack of representation in Black communities in clinical trials, just I mentioned, it leads to less efficacious treatment, and the data is not reflective of their unique genetic and epigenetic factors. And then this all leads to a poor quality of life, increase to increased morbidity and mortality. So if we can improve here, we will improve here. So that is sort of the flow that we are trying to communicate today. And what are the number of factors that lead to this? I mean, there are, information about clinical research is not out there, and that is one of my goals, to increase the knowledge about clinical research. There are, of course, multiple socioeconomic factors. If you're the single caregiver, you have to watch your kids, you're a young person, and of course, you don't have childcare, and going for clinical research needs certain commitment, needs certain resources, which, obviously, if there are lack of resources, people are not. And then, of course, there are biases and there are mistrust, which are very well, there, good reasons for that. Of course, I don't have to tell this audience, but people know very well that there are things that have happened in the past that has led to this mistrust of the system, mistrust of the clinical research. And but I think things have changed, and this is one of the other tasks I have, is to dispel some of those myths, to remove some of those biases and the mistrust, and tell you that no, it is safe to come for clinical research. So basically, try to bring these together, and coming for clinical research is important. And at the very end, we are at this point, and then we have to get to this point. So how do we do that? So we have community engagement, building trust, which is one of the events such as this can increase community engagement, can increase building trust. Then dispelling myths, and of course, during the discussion, if somebody have any questions, I'll be happy to answer, to dispelling some of those myths. And of course, increasing information always helps. And one of the things that I've been involved is called peer-to-peer mentoring, where people who have lupus, who have participated in clinical research, can go out and talk to other people who have lupus and tell them, no, I've participated, it's important. And also, it's more important that if you hear from somebody like you who is going through this, the chances of participation have increased, and studies have shown that in multiple models. And one of the effort that I'm involved is to do the peer-to-peer mentoring. And all of this will, of course, lead to improved health outcomes through participation in clinical research. So this is my message for today. And of course, we're going to go to discussion phase now, part of the meeting today. And at the end, I just again would like to thank the organizers and thank you everyone who is on this webinar today for participation. Thank you.
Thank you, Dr. Hasmi, for setting the stage and for getting us started with this conversation. Of course, the clinical information is so important for us, but it also helps to have that personal story to help really understand what we're talking about. And so I would like to invite First Lady Cora Carter to tell us a bit about your diagnosis story and your journey with lupus.
Okay, good afternoon, everyone. I was 37 years old when I was diagnosed with lupus, and I am now 66 years old. But the day, I'll never forget the day I was diagnosed. It took a long time. It took several years for me to get the diagnosis. But the day I got the diagnosis, I left my job and I went to the doctor for just an appointment. I didn't know what he was going to say, but it turns out that he said, we finally have gotten to a point where we have a diagnosis. And when he told me I had lupus, he said, you do have lupus and you only have about 2 more years to live. And I said, okay. So I held it together there and I got my car to go back to work. And I got halfway to work and I had to stop and pull over because it hit me like a ton of bricks. I had 3 children at home. I was 37 years old. And he just told me I had 2 years to live. And I was devastated. But the good part about that is I called my pastor and asked him to pray for me. And I got myself together because I said, I'm going to make it. And the most important thing was to find a good rheumatologist that had some history of working with people with lupus and finding out what lupus really was. Because I had so many symptoms. When I had the rash, they call it the butterfly rash on my back. When I had the rash, I was sent to a dermatologist by my primary care. And then when I had some other things going on, I was sent to several doctors. And they were all working separately, but nobody was piecing the puzzle together to get to the final diagnosis. That's why it took so many years. But put on a lot of meds, a lot of steroids every day. Since I was 37, I've taken a lot of medications. But I went into remission in 2003. But I'm back on the track of having active lupus. But I know how to deal with it. When I get tired, because fatigue comes with the disease. When I get tired, I do something about it. I don't try to just keep going. And I managed to keep myself very healthy. So it's something that I have learned to live with. Lupus did not take me out. I took over my care along with my physician, along with my rheumatologist, along with my wonderful husband and my family. And I have managed to live with it happily and successfully. By the help of the Lord, successfully and happy. I tell everybody that if I have lupus and you are in my close circle, you have lupus too, because you have to see me and know that I'm going through something every day. The pain is excruciating with lupus, having lupus. You're in pain almost all the time, but there are degrees of pain. And I try to keep it at a manageable pain level. And I do. So, but people around me, they have lupus because they see everything I go through and they go through it with me. So that's my story. That's how I was diagnosed.
Thank you, First Lady Carter. And you said something that's so important there, which is the people who are with you, they go through it with you every day. And I want to just acknowledge and speak with Bishop Carter. We both have had the privilege and the blessing of supporting and caring for a loved one with lupus. And I say it's a blessing to be a caregiver. I know not everybody feels that way, but Bishop Carter, I would love to hear from you about what that looks like to be your wife's support person.
Sure. Just simply like to thank all of you, the National Minority Equality Forum and Dr. Hosni, who I just think is a wonderful, spectacular person, because it's not often that we run into persons who are committed to what the community is going through. And certainly, Keisha, you're doing a great job. But, you know, my wife has said it, and one of the things that rings clear is that because she has, or she's been dealing with lupus, I've had to deal with that as well. And what that means for me basically is just adjusting my life to her world. And I'm a pretty energetic person, has always been. I like going. I don't like any dead space, if you will. I like to be doing something all the time. And I've had to make some real adjustments in that, because when I'm ready to travel, when I'm ready to go, she may not feel like it. And then if we are away traveling, then she may find herself in a place where, look, I just need to sit down. I need to spend the day in the room, that kind of thing. And that's a real adjustment. I guess, you know, we're blessed, not guess, but I'm blessed to have a wonderful wife, in that she cares for me and I care for her, if you know, if that makes sense to people. And because we're that way, whatever she tells me, whether I see it or don't see it, whether I understand it or don't understand it, I accept it as the gospel truth coming out of her. So if she tells me, look, I'm just not feeling good, and she could be looking like $1 million. She could be looking like something that's ready to step out of vogue. But if she says, look, I'm not feeling good today, I've got to hear that. So, you know, it's a journey. It's a journey. And what helps us is our faith tradition. There have been many times I've just simply prayed. And I'm glad that I have come into some doctors and some medical professionals who understand that once you have exhausted all of the medical technology, once you've exhausted all of the medicine, then there is still one avenue we can go to. And that has helped her. I've seen the moments when she's talked about remission. That was like about, I guess, about a good 7 or 8 years, somewhere along there, where she had no symptoms. And I can tell you, I prayed before that time. And I just simply believe that my prayers were answered, as they're being answered now that we're talking about lupus. And I have a whole congregation, and you're right, Dr. Hosni, it might even be more frequent than 1 out of 250, but I've got a whole congregation of persons who are suffering and dealing with lupus. And in my purview as churches across the country, this is a real subject that needs to be addressed. And the clinical trials that you spoke about, we are working every day to correct the myths around clinical trials, to help persons to understand that they've got to get the information so that they can better know what our DNA looks like in this fight for lupus. So yeah, this is very real for me. I'm hoping that as my wife went into remission a few years back, I'm hoping that with the clinical trials and the other exciting things that are occurring with lupus, I'm hoping that we'll get to a place where she can say goodbye to lupus for good. And you know, I could go on and on, but I'll say this: COVID was a real devastating time for us in our church, because I can think of two persons who were diagnosed with lupus, and when COVID hit, it terminated their lives. So, it's just important that we address this piece.
Thank you, Bishop Carter. And I think that leads us to a good opportunity for Dr. Hosny to come back and talk to us a bit more about what treatment and clinical trials look like. It's really important, as we've all mentioned, to consider clinical trials, and especially for lupus, where we're underrepresented, but across the board, honestly, Black and Brown people are underrepresented in clinical trials. So I hope that everyone has open ears to this information and is receptive to it. But Dr. Hosny, can you tell us a little bit more about, excuse me, treatment and what clinical trials and clinical research looks like?
Sure, absolutely. But before I say that, if I can take a liberty to make one comment,
Absolutely.
is what Bishop Carter just mentioned. And because we see a lot of lupus patients here at the NIH. I mean, we have a large cohort going on since 1994, but not everybody is as lucky as First Lady Carter, that she has a supportive family, supportive husband. Because a lot of time, because these are very young women, they don't look sick. So they even get dismissed by their own family. So I think it's very important, and studies have shown that if you have a supportive family, a supportive spouse, it does make a big difference. And I think a lot of improvement that you perhaps have noticed has to do with having a supportive and understanding spouse and a family. So thumbs up to Bishop Carter for being supportive. Coming to your question, Akeia, my colleague Elaine Poncio is also in attendance, and she has some information about clinical research and how to be involved in clinical research, and I've asked her to post that in the chat. Basically, when we talk about clinical research, there are two major distinctions that I would like to make. So one is the clinical research in order to understand the disease and what happens with the disease. And that is called more like an observational study or a natural history study. So it's very important that people get involved in that. And we have a study like that going on at the NIH since 1994. So we are looking at patients over the last almost 30 years, what has been going on with them, where we don't give them any medication, but we try to understand that, for example, why Black people have more lupus, why they have more severe lupus. And then the second part of this, of the clinical research, are the clinical trials that you have mentioned, where we are trying to identify various medications. And if it goes through various processes, so first there is an internal ethical review, and then there's a scientific review. So they want to make sure that what we are proposing is scientifically valid. And then there is an ethics review, which is basically concerned with making sure that the patients are protected and we are not doing anything which will minimize the harm. That is the number one thing. And I'm part of the IRB, so I know how things go there. And once that study is approved, then there are a number of different types of studies. Some are called the phase 1, where we are just trying to understand how, even if this drug is safe, and then going to next phase is phase 2, where we are trying to compare what other treatments are available. And then phase 3, which are much larger multi-center trials, where we use drugs in hundreds and thousands of patients and see A is that it is efficacious, and B, that it is safe. And then the data will go to regulatory authorities such as FDA, and if they think that this study is valid, then they will approve it. Again, coming back to the point that I've earlier mentioned, not all drugs treat all patients same, and the genetic makeup makes a difference. So if a clinical trial is done where the participation of Black population is very small, we won't know that if this drug works or not. And then this, and I can tell you from my clinical experience that certain drugs who work in white people, when we use in Black, it doesn't work. But we don't know why, and we don't know which drugs we will be. So unless there are more and more Black and Hispanic participation in clinical research, we would not know what works for them, what doesn't work for them.
Thank you for that. And I do wonder, First Lady Carter, if you've ever participated in a clinical trial or considered it.
Well, to be honest with you, I did not have information about clinical trials until recently. It was never brought into our community as an option. And not until my husband started working closely with the medical profession did I know anything about clinical trials. I had heard about them, but lupus, having lupus, it was such a questionable disease that, you know, we knew trials were going on, but we didn't know the difference between Black and brown versus white people. And so, no, I just didn't have the knowledge. I am totally in favor of participating. And my daughter, who is 38 now, she also has lupus. And so we together want to participate in clinical trials because I'm sure that's not totally normal.
Well, that brings up a good point, and I think an additional question for Dr. Hosny that we've probably heard before is there a genetic component to lupus? We hear that First Lady has it and her daughter has it. So is that a concern?
Yeah, so there is a genetic component to lupus. So just kind of back off a little bit to give a little bit long answer to a short question, is that our current understanding about lupus is that it has two components. So people are born with certain genetic predisposition to get lupus, and then something else happens in their environment, whether it's a chemical, whether there is an infection or something in the environment, or could be multiple factors that triggers that genetic predisposition to go on and develop lupus. Now, depending on what kind of, how many genes that you inherit from your parent, then the chances of the offspring of getting lupus goes higher and higher, and that will also make them get lupus at a much younger age. So the younger the age, getting lupus means some more genetic component. But at the same time, I also want to give sort of one kind of a good news is that it's not a huge genetic component. It's not like one-on-one. So if, for example, a mother has lupus, the daughter or the son will always have lupus. It's not that. The genetic risk is there, but it's not a very high genetic risk. And the reason I want to bring that up specifically is that since most of the women who get diagnosed with lupus are in the childbearing age, and then studies have shown that they can have a good life in terms of their fertility and reproductive health, in terms of they won't like to have children. And so don't, you know, have this fear that if I get pregnant or if my child will have lupus. It's not, you know, the risk is not very high, but risk is there.
Can I ask a question?
Absolutely.
Dr. Hosny, I understand that lupus can exist among males, persons of color. And of course, we only hear about females, in the Black and brown community. How is, you know, what is the diagnosis of a male person who may have lupus, Black and brown?
Sure. So out of every 10 patients with lupus, 9 are women and 1 male. So having lupus in men is rare, but of course it's not uncommon. I mean, it's rare, but we see patients who have lupus. The sort of the issue is even more serious for men, because not only is that you know, a lot of healthcare professionals don't consider men having lupus, but once men have lupus, their lupus actually tend to be much more severe than women who get lupus. So it's not as common. So 9 to 1. But when as a male you get lupus, then, but the symptoms are pretty much similar though. So again, just to kind of for general information, for people who may not have a chance to interact with somebody with lupus, the symptoms in the outset are very non-specific. They would feel that they are just fatigued, tired, they're just not able to do their day-to-day activity. So very non-specific, and hair loss and joint aches and pains. And so a lot of time, even patient themselves, especially for men, they just disregard their symptoms. They said, you know, it's nothing. So, but again, you know, you brought up a very good point. But the symptoms somewhat are very similar. It's just much more severe.
So I would imagine, just like in the clinical trials for female, the clinical trials for males is even more devastating in terms of health.
Yeah, I mean, because we don't have as many male lupus patients. And this is also an area of research that some of our colleagues at the NIH are looking at, that what is the difference, sex differences in terms of the immune system, how the immune system is different in men versus women, and how the medications are different, how they respond to medications different. But it's, like you just said, very rightly said, that it's even more difficult to do studies because there are just not that many men with lupus.
Got you. Thank you.
And I do want to circle back to Dr. Hosny brought up a good point about having a support system when you are living with lupus and how important that is in terms of improving outcomes and overall. And I would like to give the opportunity, if people, I saw somebody already dropped a resource in the chat for the lupusinitiative.org. I believe we might have a member of Lupus Chat on the call. Please feel free, if you have support groups out there, if you have resources, to drop them in the chat to help connect people. That way, if we do have people who don't have that built-in support system, they have somewhere that they can go for more information. And I'm seeing comments in the chat, so I just want to make sure that we are responding to anything that is in there. And if you have questions, please take the opportunity now to go ahead and start dropping them into the Q&A, dropping them into the chat so that we can make sure that we get to them. Before we do get to those questions, I would like to give our panelists an opportunity to share just any final thoughts or any information that they would like to share with young people to help them prepare for a diagnosis. And I would love to start with you, First Lady Carter.
Yeah, I come across a lot of women that are either having symptoms and not having the right direction. They don't know that whether they have lupus or not as of that moment, but they know that their hair is falling out and they know that things are happening to them. And so I've talked to a couple of women who were just devastated because their hair was falling out and all of that. And, I told them, you can live with a wig. That's not the most important thing. You can always buy hair. You don't have to, fret over this. The important thing is to find a good doctor, take your meds, and relax yourself and take it one step at a time. One step at a time, one day at a time, 1 month at a time. When I was first diagnosed, I went to the doctor every week. Once a week, every week for about 3 years. And then I saw myself going every 2 weeks and then once a month. And the first day that he said, I'll see you in 3 months, it was celebration time. But I was walking through one step at a time. My grandmother told me, you eat an elephant one bite at a time. And lupus is a big elephant. And to eat it one bite at a time, don't think about tomorrow, think about right now. There's sometimes I'll wake up in the morning and my eyes are open, but my body's not going to cooperate. So I just stay there until my body catches up with my eyes. And then I start my day. And I prepare for that. If I know I have to be somewhere at 9, my alarm is going off at 6. That gives me ample time to do whatever I have to do. And if I have time left over, that's all good. So you have to really just take it one step at a time.
Thank you for that. And that is so important and such a good mantra for approaching any of life's challenges, honestly, but to think about it in terms of lupus, and you've been here, you've been in this for, I think you said about 30 years now. So, and I love to see that it is working for you and that you're able to stay so positive and beautiful and radiant all the time, every day you show up. So I appreciate you for sharing your story. Bishop Carter, is there anything else that you would like to share with people?
Yeah, I would just like to say that I have a commitment for people. I have a commitment for their spiritual development as well as their physical development as well. And I see people every Sunday and certainly during the week as well. And I see the health disparities that exist. And lupus is very real. I want to thank Dr. Laura Lee Hall for leading us in putting together the Faith Health Alliance, which is an organization of churches that stretch across the country. We're about 25 strong, and these are pastors, and growing, I should say, and these are pastors across the country who have a commitment to address the health disparities. And lupus is one of the ones that rank at the top. Certainly part of the crowd that is a part of this webinar are part of the Faith Health Alliance, of which I'm grateful to have them participating. It just means that we are serious about addressing this issue. We are serious about tackling it. And I tell you, there's a statement that Derek Bell makes: persons at the bottom of the well. These are persons who feel forgotten. These are persons who feel disenfranchised, persons who feel left out, and persons who in some cases have given up. And even when we did the town hall meeting at our church just a few weeks ago, and Dr. Hosny were there were persons who walked away with tears of joy in their eyes, saying that at last we've got somebody who has heard us, or someone who can help us in this journey for good health. And so I'm committed. And again, Dr. Hosny and everybody else is going to be hearing from me, because we got to make this happen. I love my wife, no question about that, but there are many more others who are suffering, and there are others who are going through. We just simply need to help. So the church is the church community. And again, we are the trusted voice. We're the trusted voice. They may not hear from a clinic as well as they will hear from their pastor or their faith leader. And we're going to take advantage of that for the good of those who are hurting and going through.
Great. Thank you so much, Bishop Carter. And it really is, like you said, important, and we appreciate the fact that you are so committed to sharing this information and getting it out there in the community. And Dr. Hosny, we do have some questions, and I think the first one in particular is definitely for you. And of course, we will make sure you have opportunity to give your final thoughts as well, but some of these questions might help shape what your final thoughts are. So I want to start with this first question, which says, can you say something about the difference between discoid and systemic lupus? Is having the former predictive of developing the latter? So
when we are talking about lupus, I think most of the time we're talking about what is called systemic lupus erythematosus. And what SLE or systemic means is that it involves multiple parts of the body. So it can involve skin, joints, hair, kidney, and so forth. But then there are other varieties of lupus which are much limited. And one variety is called discoid lupus, where it only involves the skin, and it leaves these scarring lesions in the skin once it heals. It looks, of course, very disfiguring. And is a small percentage, about 5 to 10% of the patients with discoid lupus go on to develop systemic lupus. So not everybody with discoid lupus will have systemic lupus, but a certain subset of those patients can go on. And then again, as a part of systemic lupus, some patients will have discoid. So they're not the same thing. The disease process is the same. But when it is only limited to skin, it's called discoid. When it involves multiple parts of the body, it's called systemic. Somebody can start out with just a limited form and can go on to have systemic form, or they can just stay limited for the rest of their life.
Thank you for clarifying that. And I hope that answers the question of our attendee, but if you have a follow-up question, please drop it into the chat. Our next question, which really could be for the entire panel, can the panel comment on the role of interpersonal and systemic racism as a factor in contributing to lupus disparities, and what is being done about this? How can we transform our healthcare system and relevant lupus-related policies? That is a deep question. It is an important question to talk about this. And I don't know if one of you want to tackle it first, but how can we basically try to work to change the system, reimagine how the healthcare system is treating disparities in lupus care?
It's unfortunate, but we do live in a racist society. We do live in a society where the have-nots are not treated as well as those who have. And for those of us who are in the Black and Brown community, it's what we live with every day. And we cannot be discouraged by what we see, but we have to still persevere and still know that there's some good people. There's some good people. I'll take my own experience as a pastor. Excuse me, let me get that. I'll take my own experience as a pastor who tries every day to live as a Christian. And to live as a Christian, that means you got to love everybody. You got to love the good, the bad, and the ugly. You just simply have to love that. And that's what helps me to make it through this society that we have. I run into good Black people and I run into bad Black people. I run into good white people and I ran into bad white people. And so when I'm just simply saying, yeah, it's there, we acknowledge it, but that can never be a hindrance for us. And when I look at this relationship that we have, this wonderful relationship that we have with Dr. Hosny and other persons, it gives us hope to persevere. So my final thought is acknowledge it, but keep pushing, keep moving.
Maybe if I can just say a couple of things, because I've been involved with minority health and improving healthcare disparities. And one of my projects, the peer-to-peer mentoring, was received the William Coleman Award for improving minority health disparities. And I mean, this is a big issue. And I mean, there is no doubt that healthcare disparities, especially since lupus involves African-American and Hispanic community disproportionately. So it's even more pronounced healthcare disparity there. But I think events like this and organizations like these help. And one thing is to improve the awareness. I mean, even among the Black people or Hispanic people themselves. I was reading one of the comments in the chat that about the Hispanic, or as Lady Carter said, that she did not even know about clinical research. So improving awareness, improving outreach, and also increasing access. And those are the two major things. So I think education, having these or similar sessions in person will go a long way. And also if we can find access, we can improve resources, definitely. Those are the things that may improve or bridge the gap.
Thank you. And First Lady Carter, did you want to respond to that as well? I think I saw you come off of mute earlier.
Actually, both Dr. Hasney and my husband have said pretty much the same thing. I'm just overjoyed that we are finally getting a chance to be heard. I've never been secretive about having lupus, but I've also never had a platform to share my experience or to talk about it. Most people don't know what it is, so they shy away from even opening the door and talking about it. Platforms like we're having right now, the town hall meetings and all of the other communications that's coming in to give us access and support. I think if we just keep doing what we're doing, we're going to make a difference.
Absolutely. And just to echo what everyone said, I mean, if we continue to have these types of discussions, encourage our healthcare providers to have open and honest conversation with their patients and work with them to make sure that they are getting the level of care that they deserve, because everyone deserves quality care. Hopefully we can get to a point where disparities are much less and more people are able to get the health outcomes that they need.
Can I
Um,
say one other thing, please?
absolutely.
I have experienced a shortage of rheumatologists in our area and all over the country. I had one very good rheumatologist. He retired, and after having me for 28 years, he had to retire. He said I was the reason. But anyway, but it's been difficult to find a replacement. And the insurance companies also have some problems in supporting patients with lupus. They don't understand when you have to get infusions and it's $25,000 a month. They don't understand that. So I think we also, not just getting the information out to the public and other health professionals, but we have to talk to the insurance companies as well. And I think they look at lupus as something that can be prevented. I'm not sure. I just know I've always had a really hard time with our insurance companies supporting some of the medications.
Thank you for sharing that. I don't see any new questions coming in, but I do want to look at the chat because we have people who have shared some information. If you are looking for resources, they have several people from different organizations have shared resources. I did drop that Biogen clinical trial link again in the chat. And we have some people who just shared some stories and information. Venus says that there is very little information for our Latino, Latina, Latinx community and understanding lupus or even enrolling in a clinical trial. Was diagnosed with lupus at the same time, found out breast cancer at 41 years of age. And there are 15% Hispanics and 18% Latinos, Latinas, Latinx, and that is the population that continues to be misrepresented and ignored. And thank you so much, Venus, for sharing that. And as we stated, you know, this is really about sharing information truly for the Black and Brown community because so affected by lupus. And so thank you for sharing the resource that you have in the chat as well to connect people. We have resources from several different groups, lupus.org, Lupus Greater Ohio, Be Fierce, Take Control, Lupus Chat. So thank you all for sharing that information. And then I'm not going to say the names of the people who shared stories because they are directed to the host and panelists, and I'm assuming that's for anonymous reasons, but thank you for sharing your stories. Of course, we are committed and appreciate your commitment to educating the community in this subject and talking about the healthcare disparities and everything. So thank you. How can we copy the chat to access the resources listed in the chat? So if you are in your chat screen and you have it pulled up in the bottom, very, very bottom right-hand corner, I believe there should be an ellipses, like 3 little dots next to the smiley face. I hope this is true for everyone and I'm not telling you any lies. If you click on those 3 little dots, there should be a menu that pops up, and at the top of the menu, it should say Save Chat. Give that a try. If that does not exist for you, if that option isn't there, then that may mean that you might need to just go through and click the links or copy them. Click them and then copy them that way. All right, make sure I'm not missing anything else. So we have a comment. There are numerous specialties that the younger doctors are not going into, and that really does go along with what First Lady Carter was saying. And Dr. Hosni, I don't know if you have any perspective on that in terms of the rheumatologist almost shortage, it seems like.
Yeah, so I mean, rheumatologists, of course, there is a shortage of doctors overall, but rheumatology especially. And it's disproportionate. Some areas have more rheumatologists and some areas don't have enough. But the population is aging and they're retiring, but the retirement rate is faster than the replacement rate. So and then I think somebody was asking how many Black rheumatologists are there. I don't have any exact number, but it's very low. I can say that. Because when we go to the meetings and conferences, don't see as many. which so disproportionately low to the number of doctors and the number of and the population. I just wanted to say a couple of things. So one thing I wanted to take off from what First Lady Carter was saying, that it's very important to include patient voice in both clinical research and clinical care. And that's a push from both the American College of Rheumatology and other associations. And we also at the NIH have once a year, there is a forum that I have established called DC Lupus Consortium, or DCLC. And we are meeting once a year. We bring all the stakeholders, patients, patient care organizations, patient advocacy organizations, and various rheumatologists and other people involved. And we just sit together in a room and say, okay, what is it that you want us to do? What are the things that is on your mind? And based on that, we build our agenda in terms of research that we have to do. I believe Elaine has put down her email address and my email address there. So anybody who would like to contact us, please use that email address and be on the lookout for the announcement of the next DC Lupus Consortium, or DCLC, usually in May, so next year, May. So you have about a year or so. Yeah. I think as we have talked, focused a lot on Black community, but at the same time, Brown, Hispanic, they are equally disproportionately represented. And again, their disease is also very severe. So we are equally interested in having them involved in clinical research. All of our research material is translated automatically in English, in Spanish. So everything that we have, informational material, consents, you have it both in English and in Spanish.
Great. And we're coming up on the last few minutes. Dr. Hosny, is there anything else that you wanted to share? There is one question about thoughts on holistic medicine as it relates to arthritis.
Yeah. So I think the holistic medicine issue is a little bit complicated, because there are a lot of claims, but of course these medications don't go through the same process as the rest of the medication. My usual take on that, if somebody as a patient comes and asks me, I said, if it is working for you, it's good. You should continue, but there is not enough evidence to say that it works. There are certain things that have shown, like turmeric has shown to be helpful. And a lot of people have, it has immune effects and has effects on arthritis. Ginger also have shown to have some effect. But at the same time, having a holistic approach is important, because, in the past, we just didn't think about the mind-body connection and how the body, how the food and environment affects our body. But having a holistic approach, eating healthy, keeping active, having good sleep, all of those things are important. So, it has to come together. Just medication and just seeing a doctor is not enough, as we have now come to realize in medical field and as patients as themselves do.
Great. Thank you so much. And we're down to the last couple of minutes here, so I want to make sure we respect everyone's time. Thank you to our panelists for joining us, for sharing your insights and this important information. This discussion will live on. It'll be on NMQF's YouTube. I will put the link in the chat right now. So once we're able to get the recording up, we will. Please feel free to check it out, share it with people who may need connection to more information. If you have any questions that come up, please feel free to reach out to our team. We can certainly pass them along and help you get connected. Use the links as you can to connect with resources, to connect with our panelists, etc. And thank you so much, Dr. Hosny, First Lady Carter, Bishop Carter, for your time, for sharing your stories, for sharing your information. We really appreciate you and value you so much, and for your commitment really to just increasing this awareness about lupus throughout the community. So thank you all, and we hope you enjoy the rest of your day.
Okay.
Thank you so much.
Right.